as she plays the video and the slides to come up. Good evening, all of you. I welcome you all on behalf of the live webinar on IUI Challenges to Success from the combo Tapizar, Oxy, and the Foxy Infertility Committee today. And let us start the webinar with a prayer as usual. Can we have the prayer song, please?
எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறந்து எந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you. Let's also continue with the e-lighting of the Kuttuvilakku, which is the tradition that we usually follow at Tamil Nadu. Thank you. Going straight into the introduction of the Vice President of Tapizar, the immediate past President of Oxy, the Joint Secretary of TNFOG, a renowned senior consultant of reproductive medicine and sexual medicine, Director of Akash Fertility Center and Hospital Vadaparani. Let us join hands to welcome Dr. K.S. Cherani Kamraj ma'am to start the webinar, introduce people, introduce the guest of honor, and do the needful, ma'am.
Thank you, Madhu. Thank you for your kind words. Good evening, one and all, and it gives me a great pleasure and honor to welcome the chief guest of this webinar, Dr. Amit Patki sir, and the guest of honors, Dr. Sujata, Dr. Sanjeev Reddy sir, and the co-convener of this webinar, Dr. Kalpana, and the senior Tapizar President, Dr. Sarath sir, Secretary, Dr. Radha Vembu, and the Oxy President, Dr. Vijaya, Vice President Sampath, and Secretary Geeta Lakshmi, and the senior speakers, Dr. Anuradha, Dr. Indu, Dr. Ramesh Raja, and my dear Kundave, and all the senior Tapizar fertility specialists here who are here in this webinar. It gives me a great pleasure and honor to welcome you one and all for this webinar. And I really thank Tapizar and Oxy and the Infertility Committee of Foxy for joining today to talk on a very important topic, which is a very important one, is IUI, which is a basic fertility treatment we all know. And it is the very important first level of ART specialist who has to do it with a good care, which can give them a good success. So for this, we have a lot of good talks about the IUI. And we have here to inaugurate this webinar, our President Izar, Dr. Amit Patki sir, here. Can I have Sir's CV, Chitrakala? So, Sir is the president of IZAR. He's the medical director and the fertility associate of Mumbai. He's the honorary associate professor of Somaya Medical College, and he's the consultant of the Gar Hinduja and Surya Hospital, Mumbai. And he has done more than 35 publications, both international and the national journals, has edited more than 50 chapters in 50 books and edited 3 books. And he has been at 2 international patents in infertility and stem cell research. And he is a renowned TEDx speaker. And we have him here to preside and be the chief guest for our webinar. Thank you so much, sir. We are waiting for your words of wisdom.
Very good evening to you, and I bring you all greetings from Central ISAR. Thank you to Foxy Infertility Committee, to TAPISAR and Oxy for having bestowed this honor of chief guest, and thank you to Dr. Jayarani for having coordinated this wonderful webinar. I think the topics are very, very pertinent to today's practice, both basic and advanced. And I would like to thank you all for having conducted such excellent webinars, and hopefully you all will do many more in the future. So best wishes to you, Dr. Jayarani, and thank you very much for having me part of this wonderful webinar. Thank you.
Thank you for your inspirational words. Thank you, sir. And we have the guest of honor, Dr. Sujata Garg, who is a very dynamic person in IZAR, who is the vice president of IZAR, who is the consultant who is doing a lot of gynecological endoscopy and ART procedures more than 30 years. And her main area of interest is the PCOS. And she has done a lot of work in stem cell in gynecology. And her major achievements and honors, she has got the best graduate and 7 gold medals, both in the undergraduation and the post-graduation. And she has been credited with the first IVF baby of the Eastern Orissa, the first Teasa frozen embryo and laser hatching babies from Orissa. And we have a very pleasure to see her achieve very many awards. The Prashya Award for Women Achiever from Odisha, 2019 from the Honorary Governor of Orissa, Devi Awards for Dynamism and Innovation from Chief Minister of Orissa, and she's the Brand Icons Excellency Award in 2018 for the Best IVF Center in East India. And she has to her credential a lot of publications and research, more than 18 original publications related to PCOS and male infertility in PubMed, written many chapters for books and newsletters, reviewer of many international journals. And right now she's our vice president of IZAR India and the executive committee member of PCOS Society and the Fertility Preservation of India, chairperson of the Odisha chapter of IZAR. We welcome you, Dr. Sujata, and we wait for your words of wisdom.
Thank you so much for your elaborate introduction, Jayarani. First, I would like to thank Foxy Infertility Committee as well as TAPISAR and you, Dr. Jayarani, for remembering me and giving me this honor of being there for your webinar. I know this is a very important webinar for you, and you've chosen such a fabulous topic, IUI, which never goes old. Whenever you hold a IUI, either in person or webinar or any form of meeting on IUI, it is very well attended. I'm sure today also you have a very good galaxy of speakers and nice topics, and I'm sure your delegates will take back a lot home from today's webinar. All the best, Jayarani, for a wonderful webinar. Thank you once again.
Thank you, Sujata. Thank you for your nice words, and thank you. And we have now with us our dynamic and our efficient, and the person who is the founder, president of TAPISAR, Dr. Sanjeev Reddy sir, who is our guest of honor. We welcome you, sir. Sir is the professor of the Department of Reproductive Medicine and Surgery of Sri Ramchandra Institute of...
Not necessary. Just this is enough. Thank you.
Okay. Sir, but for being the guest of honor, it is our ritual to welcome you, sir, with all your CV. It's always an important part of the program, sir. So, sir is a special awardee of the BC Roy National Award 2050 as an eminent medical teacher presented by President of India. He has the distinguished Faculty Award in 2020 from Sri Ramchandra Institute of Medical Sciences in Chennai. And he's the champion of ISAR Award in ISAR 2020 conference in Hyderabad. And he has an IVF Icon Award he received from Asia GCC IVF Icon Award in 2021 in Dubai, and Icon Award in Economic Times 2022. And he has got the ISAR Durusha Lifetime Achievement Award in ISAR 24 conference in Bhubaneswar. And his special interest is being in the preparing the syllabus for the FRM fellowships and clinical embryology and the university with the OSR Universities of Health Sciences, Vijayawada. And he's our past president of TAPIZAR and the past president of OXY. And he has organized so many national and international scientific congresses. And we are very much proud to have you, sir. Over to you for your words of wisdom, sir.
Thank you, madam, for your kind introduction. I'm very happy the topic you have chosen. It's a good start actually for the new committee. I wish them all best for the coming 2 years. So this type of thing, instead of duplicating, joining together societies, OXY and TAPIZAR, and taking the type of topics combinedly like that, it will be not only for the infertile specialists, usually the gynecologist practicing, whoever is practicing gynecology also, they all will be interested in this topic, and they will have a lot of doubts in this. When to do the IUI, what are the factors that is going to affect the outcome, all these things. You have selected very group of people who are going to clear their doubts. In the future also, Vijaya is there. I'm requesting Vijaya also combined with this type of societies together, so that everybody will be benefited instead of like grouping like that. Few people will be sitting in one room, other people conducting the webinars and conference in the different place, in the same place, different rooms. That is not going to help. This way, combined type of joining together, we can save money, and also all the delegates will get benefited because of this one. This is nicely taken topic. Topics also is good, speakers also is good. I congratulate Dr. Jayarani, Dr. Sarath, and other team members for TAPIZAR. Hope it will do in the coming months also like this. All the best for your CME. I will be very happy when it grows like beyond this. Thank you.
Thank you, sir. Thank you. Thank you for your encouragement, and thank you for your wishes. And definitely we will work whatever you have made so far. We will also bring it to the best out of all the new AC committees, sir. Thank you so much, sir, for joining us and giving your words, sir. So we have, Kalpana is not here. She has some family commitments. Her father is not well. So Kalpana could not join. So I'm very thankful to all the senior members who have joined here. And I'm very thankful for the chief guest and the guest of honors for gracing this occasion with their valuable presence. Thank you so much, sir. And we will be going to the academic session. Over to you, Madhu.
Yes, ma'am. So as we delve into the academics, the first topic for today's webinar is going to be the topic of the need of hour. Successful ovulation induction for IUI. The chairpersons for this session are going to be Dr. Dhanabhagyam Madam. She's a medical director of Sudha IVF Centers. She is the secretary of Erode OG Society from 2001 to 2003 and has conducted many live workshops of laparoscopy IVF and Foxy MTP workshop. She's been a national speaker and chairperson and member of ESHRE and ASRM. She's received the Best Doctor Award by State IMA in 2005 and 2007 Best Woman Award, and 2018, 19, and 20. She's been an inspiring gynecologist and IVF India Award by Economic Times at New Delhi. Welcome you, madam, to chair the session. The co-chairing person whom we have, Dr. Silambuchelvi, madam. She's the managing director of Sri Shiva Hospital and Vamsam Fertility Research Center. And she is affiliated to Coimbatore Medical College. She's been the president of Coimbatore chapter of TAPIZAR and she's a former vice president of Kovai OG Society, and she has many publications and awards, which she has presented various papers and conducted CMEs till date. She's conducting FOXY recognized training courses in reproductive medicine. She's conducting the postdoctoral fellowship in reproductive medicine affiliated to Tamil Nadu Medical MGR University. Over to you, chairpersons, to introduce our speaker.
Good evening, everybody. I'm so proud today to start our first TAPISAR meeting, that too live webinar. I am so proud today to introduce Dr. Anuradha Kaur. She is the Director of Nurture IVF Bangalore, Member Managing Committee Clinician ISAR 2024 to 26, and Joint Secretary of Karnataka Chapter ISAR 2021 to 23, Honorable Treasurer Karnataka Chapter of ISAR 2023 to 25, currently practicing infertility related endoscopy at Bangalore. She's MBBS from prestigious King George Medical College, Lucknow, MD from Government Medical College, Srinagar, Fellowship in Reproductive Medicine from RGUHS, Bangalore, 15 years of rich experience in the field of infertility and ART, articles in indexed journals, authored several chapters in various books. I think IUI is, for her, IUI is just a small pinch of cake today. So let us start, madam. We invite you. We are very, very pleased to invite you to give your lecture, madam. Thank you.
Good evening, all the respected doctors present today. I thank TAPISAR. I thank South Indian Obstetrical and Gynec Society and FOXY Infertility Committee for giving me the chance, and above all, Dr. Jayarani Kamraj, who just messaged me, do you want to do it? I said, yes, why not? So thank you so much. It's an honor to be here today. Can I share my screen, please?
Yes, ma'am.
One second, I will just. Can you see the slide?
Yes, ma'am.
Okay. Thank you. Am I audible?
Yes, ma'am.
Yeah, you're audible.
So, very commonly done IUI by all the IVF specialists, by all the gynecologists. So today's topic, very interesting, ovulation induction in IUI cycles. Now, why should we do an IUI? Because natural per cycle conception rates decline as the number of failed conception increases. Young couples who have not previously conceived, the pregnancy rate per month is 30% in first 2 months. It goes to 8% after 6 months and 4% after 9 to 12 months. Also, female age is an important impact on fecundity rates, and live birth rates decrease after 35 years of age. Now, treatment with IUI is shorter, less invasive, less expensive as we compare to the IVF. Also, the pregnancy rate cycle with IUIs is comparable but not equal to IVF. Now, evidence supports ovulation induction should be done in IUI cycle as compared to a natural cycle IUI, because the likelihood of pregnancy increases with ovulation induction. And if it is chosen properly and done scientifically, we can decrease the burden of IVF ICSI by 25%. A well-timed single IUI works better than two IUIs. So single IUI has equal success as compared to double IUI. Indications, I think I'm not going into this, but yes, we do have a plethora of male factors and we have female factors on the other hand. The prerequisite, yes, we all know that one of the tubes should be patent and total motile sperm count should be minimum 5 million, though 8 to 10 million is what gives us the best result. The types of IUI cycles: natural cycle IUI, modified natural cycle IUI, then ovulation induced by ovulogens, which are given orally, and oral plus gonadotropin cycles, only gonadotropin cycles, gonadotropin antagonist cycles. Now, if we talk about natural cycle, now people may ask us that, ovulation induction, IUI has better clinical pregnancy rates. Yes, it's true. But so why do we do a natural cycle? Now, natural cycle IUI, if a female is young, she is ovulating, and there is no other abnormality in that patient, and husband is azoospermic, or he is not able to perform intercourse, he has erectile dysfunction, these candidates you can do a natural cycle IUI. Whereas in other indications which are proper, which are unexplained infertility, endometriosis or other things, there it won't work. So what do? In natural cycle, we do not give any ovulation induction, either orally or injectable. Just track the dominant follicle. I would say we do a day 2 scan to rule out any ovarian cysts and track the dominant follicle. When it reaches around 18 mm, you can trigger. Though in natural cycle, if it's a pure natural cycle, you need not trigger it. You can you can either follow with the ultrasound monitoring, or you can use LH kits. And if you are doing, you want to time your IUI in a better way, then you can give a shot of HCG 5000, and after 36 to 40 hours, you can do your IUI. Now, LH surge monitoring, if we are doing with the LH kit, wherein we do every morning urinary, we check we have one LH kit wherein put a drop of urine and check whether there's a single line or a double line. So why do we need this LH surge monitoring? It's because it's more physiological, but it requires weekend support. The natural LH surge can occur anytime. But USG monitoring, if we do scans, it is more structured and the timing of IUI can be planned. And generally, ultrasound monitoring is very correct compared to the LH surge. We may miss the LH surge. Now, timing of therapeutic donor insemination in natural cycles, HCG versus urinary LH monitoring. This was a study wherein they showed that home monitoring of endogenous LH surge with urinary kit was more physiological and convenient rather than ultrasound monitoring and HCG administration. It can be offered to women undergoing therapeutic donor insemination in natural cycle. Also, we are in cities, urban areas, but there are some patients who travel 50, 100, 200 kilometers for IUI. So for such patients, probably urinary kits, if they have the intelligence, urinary kits would be better and compared to going for ultrasounds on alternate day or daily. They may not have ultrasound available in their villages. So there also it will help. Now, controlled ovarian hyperstimulation with IUI is more successful after recombinant HCG rather than spontaneous. Now, this was another study which said, no, you should give the HCG and you get better, success pregnancy rates. And this was more seen in recombinant FSH medicated cycles. Now, IUI, that is, we go on to the proper ovulation induction. Now, how should we do it? Of course, it is done with medication. Little bit, let's go to the basics. As I was talking about the LH kits. So when the period starts, generally from day 10 to day 11, the patient will start monitoring if she has a regular cycle. Now, LH kit can be used only if patient has regular cycles. So you start monitoring from day 10 to day 11. And once the LH starts rising, it takes around 24 hours to reach the peak. And another 10 to 12 hours later, the ovulation will occur. So total from onset of LH surge to the ovulation, we all know it takes around 36 hours. So that is how the LH kit will work in this direction. Now, there's a concept, since we are talking about ovulation induction, there's a concept of FSH threshold and window, which I want to discuss. Now, we all know that in the luteal-follicular transition, the FSH levels will increase and a cohort of antral follicles are recruited from the pool, and atresia is prevented in these cohorts. They are stimulated for further development. And for this, to achieve this, the FSH concentration has to reach a particular one level to induce the ovarian activity. That is, for the follicle to grow, the FSH has to reach a particular level, which is called the FSH threshold. And Brown and all, they said that they did these studies and said 10 to 30% rise above the threshold is good enough for follicular development. Limited. Now, this is about the threshold. Now, there is something called as window. Like we have a window of implantation, similarly, FSH window. So what is it? So FSH concentration, once it reaches that threshold, it has to be maintained for a certain number of hours there. So the limited duration of elevated FSH levels above the threshold for getting a single dominant selection. That's the FSH window. So all our ovulation inductions, gonadotropins, they all work on these bases, these two bases. Now in PCOS, again, we have this problem that if we give very low doses and all, we don't get no response, no recruitment. We have all faced it and we cancel the cycles. But what happens if we increase the dose, we cross the threshold for stimulation, it just booms up. There is polyfollicular development, hyperrespond, and we can land with OHSS. So it is very critical for us to understand what is the threshold for stimulation for ovulation induction in polycystic ovary patients. So what are the principles of ovulation induction? The first and foremost, the doctor, the patient, everyone wants to achieve pregnancy quickly. Avoiding OHSS, we have no right to have ovarian hyperstimulation syndrome and patient landing in trouble, giving them iatrogenic OHSS when we are doing IUI cycles. And even IVF for that matter. But then we can prevent that IVF thing. But OHSS in IUI is not acceptable. Avoiding multiple pregnancy. Yes, because multiple pregnancy is a high-risk pregnancy. The cost of incubators later on, premature births, abnormal presentations, all those things are there. Now, what is an optimal controlled hyperstimulation in IUI? So, our aim is to get 1 to 3 follicles, 18 to 22 mm. Triple layer of endometrium more than 7 mm. IUI day should be around between 13 to 16 days. And we have to correct subtle ovarian and luteal phase dysfunctions. Very important. What are the protocols? We have oral ovulations, clomiphene citrate, letrozole. Then if the CC letrozole is combined with gonadotropin, it's combined. And then we have only gonadotropin IUI cycles. The protocols used, I'm just going to tell what happens to the clinical pregnancy and live birth rates. If we are using gonadotropin plus IUI, the clinical pregnancy rate is best 35.5%, live birth 32%, CC plus IUI 28%, and LBR 23%, letrozole plus IUI 22%, and live birth rate 18.7. What influences the response of this ovulation induction? What will age? Age is the single most parameter which will tell us whether we have a good response, poor response, no response. This is very important. The older patient, the lower the AMH, the response will be lesser, and younger patients will have better response. BMI, yes, obese patients, they do not respond to medication. And so we have to give them lifestyle changes and all. There are racial discriminations, genetic profile. What is the cause? Like, is it endometriosis? Is it PCOS? Every cause, whatever we have determined, will influence the COH. Duration of fertility, yes, longer the duration, IUI success rates are slightly less. Overall health and nutrition of the patient. So what do we do before we start the ovulation? We do the hemogram, infectious screen, sugar, thyroid. If it's high, you have to, TSH is correctable. You have to put them on medication. Prolactin has to be taken care. AFC, AMH has to be done. Tubal patency test is to be done. At least one tube should be patent. And laparohysteroscopy as per indications. And one natural cycle follicle monitoring if possible. Prior to IUI, if you are finding out whether the patient is ovulatory or not, it would be good. Generally, patients, when they come to us, they would have already done that, and you can look into those papers. How do we start? We call the patient on day 2 of cycle, do a baseline transvaginal scan, rule out any residual follicle or corpus luteum, look at the previous treatment history, previous IUI failures, counsel the patient regarding the outcome, and give them actual figure, no false hope. Patient will come to us, give them the actual figure. See, your pregnancy rate is around 20 to 30%, not more than that. That is if the best hands, best center does. Now, in short, clomiphene citrate letrozole. Clomiphene, we know it's a SERM. It is a tissue-specific agonist-antagonist action. It has a longer half-life, 5 to 7 days, multifollicular development, adverse effect on because it's got anti-estrogenic effect. So endometrium could be thinner, poor cervical mucus. We do have CC resistance and failure in 15 to 40%. Chances of multiple gestation because multifollicular development. OHSS is more here. I had a patient who had just clomiphene taken and I had to, her OHSS developed in that. She was to, induction was done outside. So it can happen just with clomiphene. Decrease uterine blood flow. Letrozole, it's an aromatase inhibitor, shorter half-life, monofollicular development, endometrium, cervical mucus are not affected, decreases total required dose of gonadotropin. Chance of multifetal gestation OHS is lesser, better clinical pregnancy rate LBR in PCOS. Now, clomiphene action is through blockage of estrogen receptors and hypothalamus, and that leads to inhibition of negative feedback of E2. More FSH LH is poured into the bloodstream, and that increases the follicular development. And consequent to the development, LH surge and ovulation will occur. Now, this is the same slide. Dosage, it can be started between day 2 to day 5. Minimum starting dose 50 mg and maximum dose up to 150 mg. Majority response, like most of the IVF specialists here, we all start, even I start with 100 mg per day. The reason being, I think mostly we receive patients who've been already stimulated outside and then they come to us. So it has a good ovulation rate, 60 to 85%. Pregnancy rates are good, 30 to 40%. And we have to remember the chance of getting pregnant is maximum within first 3 cycles. This is very important. What is CC resistant? It is failure to ovulate after 150 mg. When you reach the maximum dose for 5 days, for at least 3 cycles you have given and she doesn't ovulate. So she is resistant. 15 to 40% PCOS patients will have this. Obesity, insulin resistant, hyperandrogenemia, which is a hallmark of PCOS, those will be affected. CC failure is that ovulation is present, but after 6 cycles also, they do not conceive. So I think this we should skip. These are the letrozole mechanism, aromatase inhibitor it is, and so it decreases the estradiol feedback on the pituitary, and more FSH pituitary senses that low, estradiol is low, and then it starts producing FSH, and that's how the follicle grows. Okay. So letrozole 2.5 mg OD. It's a flow chart which I would like to tell that you can start with 2.5 OD. If there's no response, you can go to BD. No response, you can give letrozole, extended letrozole, wherein you start from day 2 and go on till day 10, day 11, and then you trigger with HCG. And step up letrozole is that on day 2 you give 1 tablet. Every day increase by 1 tablet. So 1, 2, 3, 4. Okay, and HCG when 20 mm lead follicle. Gonadotropins, we all know this, HMG and FSH preparations are there, and HMG has FSH, LH both. We have urinary, highly purified. FSH has only single preparation. There is urinary, highly purified, and recombinants. Recombinants are expensive. Urinary are enough for our IUI cycles. HMG, it is cost-effective response, but response is little unpredictable, difficult to manipulate dosage. But I would say with experience, you do get the hang of this drug and you can manipulate the dosage. Recombinant, the drawback is it's expensive. It does give us a predictive response and little ease in manipulating dosage. Now, which drug we should use for stimulation? Any drug. There's no difference in live birth and OHSS rates. HMG, FSH, highly purified recombinant, anything you can use, depending on the financial status of the patient. Now, this is one Sono scoring system, which is a bit interesting. It takes into account age, BMI, interfollicle count, ovarian volume, stromal resistance index, stromal PSV. So if you're doing your Dopplers there, you can get the last two. And the scoring is given from 1 to 5, depending on now age and all these. This is the chart. You can keep it in your clinic. And how do we start the dose? Now, if you get a Sono scoring score of 25, start with 25 IU. And 21 to 24, you have to increase the dose. As the score goes low, the dosage will increase. So 21 to 24, you can give 37.5, 16 to 20 Sono score, 75 IU, 11 to 15, you can start at 112.5, 6 to 10, you can start straight away with 150. How do we increase the dosage? The score is less than 10, 75 IU you have given, day 5 you can increase the dose. If 10 to 20 scoring, 75 IUI you can increase, day 7 you can increase, 20 to 22, 37.5 you can again increase day 10 if you don't have response. More than 22 you can increase by 37.5, day 14. Now this is a nomogram which is developed, individual versus standard recombinant FSH in a mild stimulation for IUI. That's an RCT. So you can see the central follicle count and weight. They have they put it in a nomogram. And then you see where your patient comes, whether you should give 50 IU, 75 IU, and 100 IU. Now, what are the regimens we follow? CC letrozole followed by gonadotropin and CC letrozole with gonadotropin. Generally, we all do CC plus gonadotropin or letrozole plus gonadotropin. That's the majority of us do. So difficulties of gonadotropin, yes, the cycle becomes expensive. Affordability is an issue. Patient has to come frequently to take the shots. And if you have no response, then, the money spent is gone down the drain. Premature LH surge is common in gonadotropin IUI and premature luteinization. OHSS, yes, and multiple pregnancies because of the multifollicular development. The major rationale, now we have CC gonadotropin and letrozole gonadotropin. The major rationale behind clomiphene and gonadotropin combination is to reduce the the dosage gonadotropin in this treatment. It does not reduce the estrogenic act. So we cannot use gonadotropin to decrease the anti-estrogenic effect of clomiphene. It's difficult to titrate the dose. Response can many times be excessive. Not for beginners. Clomiphene letters followed by gonadotropin. Gonadotropins are started day 1 after the last dose of clomiphene. I'll show you a chart also. Follicular recruitment is carried out by CC alone, and sonography is done after the last dose of clomiphene to judge the follicular development. Now, this is this step-up conjunctional regimen is you give this letrozole or CC day 2 for 5 days, and 3rd, 4th, 5th, 6th, 7th, you give shots of FSH and trigger 18 to 20 m. This is the conjunctional regimen. Of course, you have to do ultrasound monitoring. Step up sequential regimen, letrozole and clomiphene, same day 2 onwards for 5 days. And once you stop, once the 5th dose of clomiphene is over, from 6th day, you give FSH 75 IU for 3 days and monitor with ultrasound. Trigger at 18 to 20 mm. Now, it is very important, I would like to say, of course, we have folliculometry in talk next, but the gynecologist or the IVF specialist, whoever are doing these inductions, should be well versed with ultrasound. Please do your ultrasounds yourself so you can titrate the doses easily. Now, they have another study is there to compare GnRH and FSH with or without letrozole for ovulation induction. What they did is they gave letrozole day 3 to day 7 and day 7, day 8, day 9 to day 10, they gave FSH. And gonadotropin, so these are the results that what they used is around 4 ampules of they have given GnRH and FSH. So gonadotropin IUI, like if clomiphene and letrozole, say it doesn't work out, you don't get the follicular dominance and then follicle doesn't grow. So next time you can go for plain gonadotropin IUI cycles. So gonadotropin either alone or in combination with CC gives higher pregnancy rate, we know that, and a lower abortion rate. But it does increase the multiple pregnancy rate. Now, how do we do these pure gonadotropin cycles? So step-up protocol is the more common protocol which is used conventionally. Day 1 to day 5, you give 75 daily, 75 IU. And 5th day onwards, you check the scan on 5th day and you increase, if there's no dominance is not achieved, you increase the dose, double it to 150 for till another 5 days. Day 10, do scan. If you do not get the follicle up, there's no follicular growth or it's growing slowly, you can increase to 225, day 10 to day 50. So definitely.
One more minute to go, ma'am.
Yeah, I'll finish. Step down is you give FSH HMG 150 and once 2 to 3 follicles are more than 10 mm, you increase next 3 days 112 and then 75 IU till HCG administration. Now, I'll just say that gonadotropins are expensive, but there is predictable response, but OHSS is more and no effect on endometrium. PCOS, again, ovulation induction may be used without a withdrawal bleed if you have to exclude the pregnancy. Okay, so recommended doses that you give gonadotropins So basically, a step-up protocol could be fine for the PCOS. Remember, with low AMH and AFC, starting dose of should be minimum 150. This is a point. When to cancel? If there is no recruitment or you develop more than 3 follicles or E2 crosses 1800. And yeah, so premature LH surge, there we have given, like if we have documented LH more than 10 or in previous cycle there has been a premature rupture. You went for IUN at 14, 15, it ruptured. The next time you can add an antagonist. Okay. So gonadotropin cycles will need an antagonist, most likely. Pregnancy rates, again, clomiphene citrate, natural cycle 8%, clomiphene 8.9, lactozole 11.5, lactozole gonadotropin 21, gonadotropin 25, gonadotropin antagonist is seen 38%. So I think how to convert IUI cycle into IVF, you can add the antag on time, do E2 LH levels and continue same dose of gonadotropin. You can consult your colleagues or your facility, IVF facility in your area if you want to convert. So in summary, natural IUI has a role if couple is unable to have intercourse, or you can do a donor IUI for azoospermic male and if the female is ovulatory. Clomiphene citrate lactozole can be used for ovulation induction and IUI. Gonadotropins have best clinical pregnancy rate in IUI. Cancel the IUI cycles if you have more than 3 mature follicles. Counseling and written consent, most important for both the partners. Explain the success rates. Please do not give any false promises. The IUI center has to be registered level 1 clinic in accordance with ART law. This is very important. Earlier, anybody could do IUI in their center. Now you have to register with the level 50,000 is the fees for, I think, IUI ART clinics. You can pay that and get yourself. Otherwise, you cannot do IUI. Even now, earlier, people were bringing samples from IVF center or IUI labs and doing it in their clinics. You cannot do that because transfer of gamete from one center to another has been also banned now. So please register your clinics. Thank you so much. This is my village. A big thank you to everyone and thank you for a patient here.
Good evening. Thank you, madam. Thank you very much for the excellent presentation. So each and every step is important for successful IUI. The first step is induction of ovulation. Thank you very much for the simple way of highlighting the induction of ovulation for IUI. It's a very simple, cheap, and readily available technique. But of course, the success depends upon the technique which we follow. Definitely, to improve the success, induction of ovulation gives better result. Thank you, madam.
Thank you so much.
Yeah, thank you, Anuradha, for that lovely presentation. And thank you so much for accepting our invite in a short notice and giving a very nice lecture or a very nice presentation, which is very easy to follow. Everything you have given in a very beautiful way. And it is really amazing. Thank you so much for joining us.
It's really, really wonderful now. People are starting each and everyone into IVF, all machine IVF centers. Nobody knows how to do it. Today you explained such a beautiful way. Even MBBS doctor can do it. Such a wonderful way. The stage 1, like induction and how to follow, step up, step down. And in what really people, we always refer so much things for so much topics. Such a hot like topics like endometriosis, this and that, unexplained. Beautiful way you told everything so that everybody who was newly starting our.
Thank you so much, ma'am. It's an honor to hear good words from you.
First class, but I never thought such a beautiful way you are doing today's presentation. Thank you so much.
Thank you so much.
We welcome OXI President Dr. Vijaya. Vijaya, welcome you, Vijaya. Vijaya, you are here?
At the end of the session or right now?
Ma'am, questions at the end of the session, ma'am. For want of time, we're going ahead with the session 2, which will be on the folliculometry for successful IUI, which is our second topic. To introduce the speaker and chair the session, let me take the privilege of welcoming our chairperson, Dr. Asha Rao, ma'am, who is the director of Rao Hospital and CARE Coimbatore, director for postdoctoral fellowship program in reproductive medicine and endogynecology. And she has a lot of affiliations. She's a past president, Coimbatore Obs-Gynae Society, organizing chairperson, Endo Insight 2021, organizing chairperson of UVA, Foxy South Zone, IAGE Star Endogyne Conclave, and she's an ICOG Governing Council member of 2023. She's got many publications and research, and she is a person who needs no introduction. So, ma'am, welcome. And coming to Dr. Sendamarai Chelvi, Madam has done her MBBS, DGO, MD in Madurai Medical College, and she has had her conferences and membership with Foxy, ASAR, ESHRE, ASR, and IMA, and she's been practicing ART for over 2 decades and awarded as Maruthuva Mamani, Inspiring Gynecologist, and ASR Dronacharya. We welcome you to chair the session and introduce the speaker, ma'am. Ma'am, you're muted, ma'am.
Good evening, everybody. It's my pleasure to introduce Dr. Indumati Joy to talk on folliculometry for successful IUI. She is senior consultant in IVF and gynec endoscopy, Nova IVF Fertility, Anna Nagar in Vadapalani, Chennai. Experienced in the field of OB-GYN for 25 years and in reproductive medicine for more than 15 years. Executive Committee member of IFS Tamil Nadu chapter. Member of ASRM, ESHRE, Foxy, ISAR, TAPISAR, IAGE, PCOS societies. Invited faculty to conduct fellowship exams, academic webinars, and presentations in national conferences. Has authored and co-authored several papers in journals pertaining to reproductive medicine and andrology. Areas of interest: minimal stimulation protocols in IVF and gynec endoscopy. I welcome you, Indumati Joy. Over to Indumati Joy.
Thank you, ma'am. Thank you for the kind introduction. I'll start sharing my slides. Can you see my slides, ma'am?
Yes, yes.
Yes. So the topic given to me by ma'am was, by Jairani ma'am, was folliculometry for successful IUI.
Indu, your voice is breaking. I think your internet is...
Yes, ma'am.
She put in a mute, I think. It's not audible.
If your internet is very weak, you just cut your video so that we can hear the audio alone.
Already I cut my video, ma'am.
All right, okay.
And now it's audible.
Yeah, now it's clear. Now it's clear.
Yes,
Jairani?
Yeah.
Dr. Jairani?
Yes, madam.
Please excuse me. As I have told you already, I am going to airport.
Yeah. Thank you so much for joining even in midst of your busy
minutes.
schedule.
After 15 minutes. Thank you.
All right. Thank you, ma'am. Thank you. Indu, you're okay?
Yeah, yes, ma'am.
Yeah, you can continue. Your voice is audible.
Yeah, follicular monitoring. So we all know that it's a vital component of an IVF or an IUI assessment and timing. It employs a simple technique of assessing the ovarian follicles on regular intervals and documenting the pathway of ovulation. So the protocol for any follicular monitoring would start on a day 3 or a day 4 scan, which is a baseline scan. There is a overlap of slides between mine and the previous speakers, so kindly excuse. And there is a serial follicular monitoring which we follow. So why should we monitor a follicle? So that is to evaluate if the dose being used is optimal in an IUI cycle
and to adjust the dose of the drug, as some patients are hyper-responsive and some are poor responders. To find optimal time for ovulation induction, how to time the IUI, and to avoid excessive stimulation and prevent OHSS and multiple pregnancy. So how do we monitor? It is by ultrasound, and in ultrasound, it could be by color Doppler, power Doppler, and by morphological growth of the follicles. Or it could be done by estradiol alone. It indicates the functional activity of the follicles, but we cannot see the size of the follicles, or sometimes by both. And transvaginal ultrasound is accepted method in all the infertility clinics. So follicular monitoring is the most simple way of doing the ultrasound in an IUI. We cannot progress in an IUI cycle without doing the follicular monitoring. So the average of two longest diameter perpendicular to each other is the very simple way of measuring a follicle. Like for example, the follicles can appear on ultrasound in different shapes. Like very few will be spherical or round. Most of them will be triangular, or it could be a quadrilateral, or it could be an elongated oval shape. So we have to measure the follicle closest to the nearest geometrical figure possible. Like for example, if it is a triangle, then we have to measure the length and the base. If it is a spherical, then we can take only one transverse measurement, that is enough. Or it could be an oval, again it should be the length and the base. So the nearest geometrical figure is what we have to look for. So pathophysiology of this ovulation induction, just to take you through few basic slides. So the journey to ovulation begins during the late luteal phase of the prior menstrual cycle, which we should have in our mind, when certain 2 to 5 mm sized healthy follicles form a population from which the dominant follicle is to be selected for the next cycle. This process is the recruitment. Usual number of such follicles may be 3 to 11, which goes on decreasing with the advancing age. During 1 to 5 days, that is the first 5 days of the menstrual cycle, a second process of the follicular selection begins, when among all the recruited follicles, certain growing follicles of size 5 to 10 mm are selected, while the rest of the follicles regress or become atretic for that cycle. During the day 5 to 7, the 1 week of the menstrual cycle, a process of dominance begins when a certain follicle of 10 mm size takes control and becomes dominant. This also suppresses the growth of the rest of the selected follicles and in a way is destined to ovulate. This follicle starts growing at the rate of 2 to 3 mm a day and reaches 17 to 27 mm also in a natural cycle just prior to ovulation. Almost nearing ovulation, rapid follicle growth takes place. The follicle starts protruding from the ovarian cortex, attains a crenated border, and it literally explodes to release the ovum along with some antral fluid. So we can, in a very good machine, we can see this crenated border also. So ultrasound monitoring in an induced cycles and predicting the success of IUI or IVF. Most of the IVF studies are conducted after induction of ovaries with the help of ovulation induction agents like clomiphene citrate. In such induced cycles, primary determinants of the success, we see the ovarian volume, antral follicle count, and ovarian stromal blood flow. So how do we go about with an ovarian volume? It is easy to measure, although it is not a good indicator of an IVF outcome, but we can do that even for IUI and IVF, and we can learn to measure the ovarian volume, which can predict the success to a certain extent. A low ovarian volume does not always lead to an anovulatory cycle, but it's important to recognize a polycystic ovarian pattern and differentiate it from the post-induction multicystic ovaries. Follicles arranged in the periphery forming a necklace sign, echogenic stroma, and more than 20 follicles of less than 9 mm size signify a polycystic pattern in an induced cycle, while follicles in the center as well as at the periphery are seen in a normal induced multicystic ovary. So it is very important to differentiate between a classical polycystic ovary with an increased androgenic stromal element from a polycystic ovary which is actually a multicystic ovary with a history of previous ovulation induction. And then antral follicle count, we all know, is if it is less than 3, usually signifies possible failure of not only IUI but any method of ART. Ovarian stromal blood flow has been recommended as a good predictor of ART success, let it be IVF or IUI. Increased peak systolic velocity of more than 10 centimeters per second is one of such parameters which has been advocated. So significance of this is this peak systolic value is it helps in the prediction of impending ovulation and optimal timing for procedures like postcoital testing, HCG administration, intercourse, timed intercourse, donor or husband insemination, or egg collection. If not ovulating, it can be treated with ovulation induction agents. So the importance of day 2 or 3 or day 4 scans is mainly to see the antral follicle count to rule out any cyst. So any cyst more than 3 centimeters, we actually do a estradiol and the progesterone value and we correlate with that. And whether the endometrium is thin or it is shedding phase or any other pelvic associated pathology is there. We expect normal sized ovaries with very small follicles around 3 to 5 mm in diameter. Follicular size is measured by taking mean of 2 or 3 largest perpendicular diameters of each follicle. Ultrasound follicular monitoring is a serial ultrasound follicular monitoring started from day 7 or day 8 of a IUI cycle or any ovulation induction cycle. But in case of gonadotrophins, we can start scanning from early, that is 6th day of stimulation. So assessing the follicular maturity, the follicles normally grow at the rate of 2 to 3 mm per day in a stimulated cycle. Definitive size of the follicle, which confirms the maturity of the oocytes, is still controversial. A follicle measuring 18 to 20 mm has been found to contain a mature oocyte. So here, usually in IUI, I wait for about 20 mm. I do not trigger at 18 mm. So between 20 and 22, I trigger. And correlation with the serum estradiol levels, which is usually advised when we suspect a hyperstimulation in an IUI cycle. Plasma estradiol levels correlate closely with the stage of development of the dominant follicle. Serum estradiol values more than 200 picogram per ml on day 8 of stimulation indicates adequate dose of gonadotrophins. Ultrasound monitoring has totally replaced the estradiol monitoring in most centers. Predicting the risk of OHSs, which is also important. If there are more than 4 follicles larger than 16 mm or more than 8 follicles larger than 12 mm, then we need to counsel the patient. It is best not to give HCG, as we all know, so as to prevent OHSs and higher order multiple births. In case of doubt, we have to do the serum estradiol levels to correlate. Estradiol levels of more than 1500 to 2000 picogram per ml indicate risk of OHSs and is advisable to withhold the HCG trigger. So ultrasound findings in OHSs, bilateral symmetrical enlargement of ovaries of more than 12 centimeters in size, multiple cysts of varying sizes, classical spoke wheel appearance, ascites or pleural effusion, which is usually not expected in an IUI. So coming to the follicular Doppler flow studies, so when you have a hyperstimulated ovary, I've taken this picture because in this picture, it is actually stimulation for an IVF. We can understand the Doppler flow better when we see an IVF picture. A mature follicle shows vascularity at least in 3/4 of the follicular circumference. And the peak systolic volume is velocity is 10 centimeters per second. At this time, the LH will start. When the PSV is 10 centimeters, the LH surge will start. And this is the right time to give the HCG trigger. So it depends upon the ultrasound machine which we have. So if we are very confident about seeing the Doppler flow, it is only an additive thing. But most of the time, when we are confident about the follicular size and the appearance, we don't have to check this, and we are not dependent only on the follicular Doppler. It's only the additive feature. So perifollicular vascularization. So you can see, you can just apply the power Doppler or around the follicle, and more than 3/4 of the follicle will be surrounded like a ring of fire. So then we know the vascularity is good, but we cannot predict the timing of ovulation based only on the vascularity. So we have to see the size and also the overall pattern of the follicle. So predictors of a poor ovarian response will be in the beginning itself when the ovarian volume is less than 3 cc, less than 3 antral follicles. Ovarian resistance index is more than 0.6 and PSV of less than 5 centimeters per second, and stromal flow index is less than 11. So all these features will suggest poor ovarian response, and higher dose of gonadotrophin will be required for stimulation. So ovarian volume is seen on the 2nd or the 3rd day of the periods itself, and we also check the antral follicle count, and all these parameters which I have put here can be checked on the 3rd or the 4th day. It will help us in counseling the patient as to she might have a less ovarian response for that cycle. So triggering ovulation trigger, the endpoint of any ovulation induction protocol is to identify the best time for triggering the ovulation. So in a gonadotrophin cycle, what the books recommend when the leading follicle is 18 to 20 mm, and in clomiphene or in Letro cycle when the leading follicle is 20 to 20 mm, and also in natural cycle it is 22 mm. So
One more minute to go, ma'am.
Yes, ma'am. So what is the feature suggestive of ovulation? The disappearance of the follicle, that's one, presence of free fluid in the cul-de-sac, and presence of hyperechoic, smooth secretory endometrium starts to appear. So baseline prior to initializing the gonadotrophin therapy, ovary with antral follicles. This is a picture which shows the antral follicle count, and this is during the stimulation on day 5, showing recruited follicles measuring 10 to 12 mm. So this is another picture on day 7 with leading follicle of more than 12 mm. So you can see the other follicles that are recruited, but the lead follicle is what we are concentrating on, that is more than 12 mm. So on day 9, showing the growing follicles. So here also you can see that there are many intermediate follicles, but the dominant ones are less. So you can see on day 11, 2 to 3 follicles measuring 17 to 18 mm. This is one patient where we would be triggering her with a agonist. So day of ovulation induction, leading follicles measuring more than 18 mm. So we have put the Doppler. So you can see the Doppler all around the follicle. So one thing is I have discussed the the findings of a rupturing follicle. But another one finding which we should be familiar is the sudden increase in the size and a thick walled, which is the luteinized unruptured follicle. This can also happen in about 15% of the patients. So why should we monitor the IUI ovulation induction cycles? This is to evaluate if the dose is being used is optimal and to adjust the dose of drug, as some patients are hyper-responsive and some are poor responders, to find the optimal time of ovulation induction and to time the IUI, to avoid excessive stimulation, to prevent OHSS and multiple pregnancies. So these are the 5 reasons for why we insist on a folliculometry, and we cannot take it for granted that we just start them on Letros and ask them to come after 10 or 15 days, because even with 2.5 milligram of Letros and 50 milligram clomiphene, hyperstimulation has occurred. So it is very important that we train ourselves in the ultrasound and we have to monitor the patients. Thank you.
Thank you very much, Dr. Indumati. Lovely speech today. And really it is very, very full of points. What to do, what not to do. And there is always, we have an IVF setup. Suppose people who are hyper responders, like 4 to 6 or 7, more than 7 follicles when they develop, you counsel them because they develop lovely follicles for even agonist or antagonist cycle. And not an antagonist IVF cycle, that will be better for the patient as well as for us. Right? That cycle she cannot cancel. Those days, yes, they always cancel the cycles. 4 or 5 days, don't trigger, just cancel and all. Now, lovely antagonist cycles are doing very much better. Yes. So we are converting all our IUI cycles into IVF cycle when we develop more than 5 follicles. And I think estradiol level, you can up to 3,000, you can go. 3,500 is my cutoff. So you can go up to 3,500. These are some points I want to tell you. Thank you. Thank you so much. Lovely talk today. Thank you so much.
Thank you, Indu, for nice bringing out the very practical points of improving the success. That is a very important point, that as we need not rely on the sonologist. We should do it ourselves. And it is very important that for one patient, the one hand will always avoid the errors of measuring the follicles. That is very important to carry out or improve the success rate. So in that way, you brought all the important vital points of a practical comforts which we have to do for the success of the patient. Thank you so much for accepting our invite.
Thank you.
So finishing such a very practical and adorable talk, let's go into the third topic. We've seen folliculometry. We've seen how to successfully induce ovulation. The next topic is ideal semen for IUI success. To chair the session, let me introduce Dr. Vasundhara Tyagarajan, Madam. Again, a person who needs no introduction. She's a life member of many of the associations, IMA, IAHR, ESHRE, ASAR, TAPISAR, OXY, FOXY, and ICOG. And ma'am, request you to take over the session along with Madam Dr. Bhuvaneshwari. Madam is the Medical Director of GBR Fertility Center, Magappar, and a Director IRM at Rilla Hospital, Crompet, a fertility specialist and laparoscopic surgeon. She is a certified robotic surgeon, a member of many of the affiliations. She has ISR, ASRM, ESHRE, IAGE, so on. So, handing over the session to both the chairpersons to introduce the speaker, ma'am. Thank you.
Thank you, Madhu.
Hi, Ramesh. Welcome you for this session. Dr. Ramesh Raja is basically a MBBS doctor, and he has done his fellowship in clinical embryology, clinical andrology, sexual medicine, and now he is pursuing PhD in embryology. So he is as an embryologist and andrologist for more than 15 years of experience, and he is an executive member, TAPISAR 2024, IMA State Council member 2024, and he is awarded as Rising Star Award in Assisted Reproduction Technology, and is the first Indian to receive proficiency in ICSI, issued by the American College of Embryology in 2015, and published papers in national and international journals. And area of interest, quality control in IVF lab, sperm DNA fragmentation. And he is going to talk on ideal semen for IUI success. And Ramesh, you are the ideal person for this topic, and over to you.
Ellarku vanakkam. Thank you so much for your kind introduction, ma'am. My sincere thanks to Dr. Jairani Kamaraj ma'am and Saraj Patina sir and Sanjay Vidhi sir for giving me this beautiful opportunity. Can you able to see my slides, ma'am?
Yes.
Yeah. So I'm just going to talk to you about, is there any chance as an embryologist to enhance the success of an IUI by the sperm preparation for IUI? This is just for an history. This insemination has begun and there's been documented in 18th century, but it was more common in 19th century. As we all, the only thing is that for the first human pregnancy of IUI, which was a frozen semen sample, which is frozen thawed semen sample, which was documented in 1953. So this is the basic setup of an IUI lab, where is an andrology lab, where you have a laminar airflow with a microscope inside, and there is a small incubator, which is a dry incubator, which you don't want to have an expensive incubator like in the IVF lab, which have a CO2 base, and a small centrifuge machine. So this is like just to say, if suppose if an andrology lab takes a selfie, it will be looking like this, having an andrology lab. So the IUI preparation, which started with the proper counseling and also the sample collection instruction. Why? Because here I have shown you the wide mouth collection container, which will be helpful for a male to collect the semen sample without any spillage. This is much more important. And also people usually say that abstinence period should be of ideal as per the WHO manual, is 2 to 7 days. Even though abstinence period is less, we just wanted to make sure the men that only the volume of the semen sample will vary if you're having a lower abstinence, otherwise the parameters doesn't change. The another important is people used to collect the semen sample in an ordinary restroom, which will in turn have a problem with the difficulty in semen collection. See here today, still I have seen that few labs which don't have a proper semen collection room separately, people still collect in the normal restroom, but this should be avoided because we need to avoid the collection artifacts to get the good sample for the IUI. In case of any religious practice or person doesn't know how to masturbate, these are the two things which are important for the difficulty in masturbation. Like one is male factor package, which will be like a condom of non-spermicidal condom, which will be helpful for collecting the semen sample. Then the semen sample can be transferred into the container and we can give it to us so that we'll be able to process the sample very properly. Why we need to have prepared the semen sample? Because other than spermatozoa, the semen sample will contain the prostaglandins, germ cell lines, leukocytes, bacteria, epithelial cells, and occasionally red cells. This in turn is not good for the uterus environment. Only we need to have a good motile spermatozoa. So these are these few things, because these round cells, leukocytes, and dead cells, which in turn will produce a ROS production, which is actually not good for the spermatozoa. And the prostaglandins, which is placed directly in the uterus, can cause painful uterine cramping. How to prepare the semen sample? So we need to have a culture media. The properties of a culture media is just to sustain the viability of the sperm. This culture media should be incubated 37 degree prior to the IUI, at least minimum of around 1 hour to 45 minutes. And this usually this culture media will maintain the sperm motility and viability at least for around 15 hours to 16 hours post preparation. So the three important types of semen preparation is there. One will be the swim-up technique. Second will be the pellet and swim-up. Third will be the discontinuous density gradient. So this is the swim-up technique, where after the liquid semen sample transferred into the tube, you can just pour the liquid semen sample at the bottom. Then on top of it, you can have semen wash media. So they put it in the 37 degree for 45 degree and just place it for 45 minutes. So that what will happen is the viable the spermatozoa will swim through the media and will come up into the media. So it will be helpful to collect the motile viable spermatozoa in the top of the layer supernatant, and you can just inseminate with the 0.4 or 0.3 ml. So the advantage is less traumatic and the cleanest sperm population is obtained. The disadvantage is only it will take much more time, even 40-45 minutes is important. Suppose if the sample is having a low count or the sample is having a low motility or if the sample is having any agglutination, this method is not suitable for the preparation. Second technique is the wash and swim up technique. It's nothing but you're going to centrifuge the semen sample with help of a culture media of equal volumes. You need to mix it up. This culture media should be properly, come to the 37 degree prior to the mixing up. Then go for a centrifuge, take a pellet, discard the supernatant. Again, you can just resuspend with the 0.5 ml of culture media. Put it same like a swim up. Just after 45 degree angulation and 45 minutes, you can just aspirate the supernatant and you can just go ahead with the insemination of IUI. So the advantage of this technique is, suppose if they're having any viscous sample or less debris sample will be good of this technique. And in case of retrograde ejaculated sample, definitely this will be helpful. The disadvantage is spermatozoa can be damaged by ROAs, not suitable for any sample with the agglutination. The third technique is discontinuous density gradient technique. This gradient technique is on principle. Each and every cells, even the live spermatozoa and the non-motile spermatozoa will have a different specific gravity. So on base of this by the centrifugation, with the help of the two different gradients, we will be able to separate the different density gradient. I will show you the picture later. So this is how it will be separated. The viable motile spermatozoa will have a highest specific gravity, which will be in the bottom of the test tube. So which you can be able to get the motile spermatozoa at the bottom. It's very simple. There are different density gradients are there. Single density gradient is there, double density is there, triple density is there. We usually commercially use it only double density gradient, single density gradient and triple density gradient, which will be used in the normal laboratory procedure for other purposes. So double density, we need to put 80% in top layer and also 40%. Then they gently put the semen sample on top of it, centrifuge it. You will be able to get a pellet like this. So in here you can see the viable motile spermatozoa will be in the bottom. Discard the entire supernatant. And you can just pre-mix with the culture media, which is already incubated. You can directly go for injection, or else even you can put a just small top of the pellet and can just go ahead with the same like a swim-up technique for again 45 minutes, and you can be able to get the supernatant with the good recovery of motile spermatozoa. The advantage is anything, whatever you name is as abnormality in a semen sample, can be done through this kind of density gradient technique. And second, if the patient is having any sperm antibody or cariotype semen sample, it will be best method to prepare the semen sample. The disadvantage is people say that centrifugation in turn will have a superoxide formation, but the principle is very different because the silica coated particle doesn't make you to get the centrifugation, the ROS production. So it's a beautiful method to do it. The other two methods I'll just tell you, because this magnetic activated cell sorting has come up in like a boom. Like this is the machine. This is a little bit of expensive one, which will cost you around 80,000 to 1.2 lakhs. The basis is on the basis of the magnetic repellent, you can just take away the abnormal spermatozoa or abnormal DNA on top of this thing, and the motile spermatozoa will pass through very easily. But this technique has been used widely in the IVF rather than the IUI because of the one is cost factor. Second is the yield of the spermatozoa will be little lesser. So it will be very helpful in the ART, but people have used even for IUI also. Now, this is the latest one which has been coming up. People say that the microfluidics in IUI is nothing but same Petri dish, whatever we use it in the IVF lab, will have a 2-3 layers. So one layer it will have a semen sample. On top of it, you will have a small pore-like structure. You can see the filters. This is the second one. In this pore, actually, people say that the motile spermatozoa, which is having a good shape and structure and other things, it will pass through the pore and come up like a swimmer. Then you can collect the semen sample. People started using it. I myself have started using it. The only problem is the little concern over the cost factor, because it will cost you around more than 6,000 to 7,000 rupees extra for a single IUI. But it has been less number of IUIs has been done. But for an IUI, for an IVF, they have done for many samples. We feel that it is a little improvement in the fertilization, cleavage rate, and the blastocyst rate. Pregnancy rate yet to be, calculated compared with the other things. The ideal picture of this is like left picture will be having a semen sample of raw semen sample. The right, you can see only the motile spermatozoa will be separated from the other debris. So the thing is, we need to inject this clean spermatozoa, motile one, into the IUI. And another important is the sample loading, because the one thing is, once the patient has been collecting the semen sample, the collection time to the preparation time and the insemination time is much more important for getting a good success rate in IUI. For an example, if a sample is given, usually 15 minutes, after 15 minutes, once the liquefaction has happened, we check for the liquefaction and start preparing the semen sample. So it should be inseminated, the post-choice should be inseminated within 45 minutes to 90 minutes. There are so many papers, and we have personally also experienced that before 90 minutes of sample collection, if you do an IUI, the success rate is a little better than an IUI. So assess the post-choice sample and just load it in the catheter. This catheter, there are different types of catheter. It all depends upon an individual person, how they are used to it, and it will be easy for the patient to inseminate. So the difficulties when we'll come to an IUI is, one thing is, the surprises will be there on the day of IUI. So in this, the patient will have given semen sample for, semen sample for analysis. That time the sample would be of normal value. If it comes to an IUI, there will be a poor sample, or if it could be of even azoospermia. This can happen. Why? Because the new place or the tension or stress of the patient could be only the ejaculated sample doesn't contain any spermatozoa. In case, you can just go ahead with the second ejaculate. Usually, a second ejaculate will be better than the first ejaculate. Or even you can ask the patient to go ahead with the home collection with the consent form. Don't forget to get the consent from the patient after collecting the semen sample from the home. Nothing harm in getting the home collection. The only thing is we need to get consent from the both husband and wife saying that the semen sample has been collected from the husband. And also the time given for the home collection is 45 minutes to 1 hour. They should collect the semen sample, put it in the body temperature, either in the pant packet, the shirt packet, and just come to the hospital. But make sure he collect the semen sample in the hospital. Even for semen analysis, ask him to collect the semen sample in the hospital environment, because if there is any spillage or anything, we are not, it will be responsible that even the cycle cancellation can be happen in the IUI. And next is suppose if there is any low count, if the patient is not willing for other things, even pulling of the semen sample will have a proper, get a good amount of spermatozoa for insemination. In this case of pooling samples, the cryopreservation will have a role on this IUI. So this azoospermia and very poor semen sample can happen on the day of IUI. Then the problem difficulty is the abstinence. Suppose the patient will have yesterday night we have undergone intercourse and I don't think so there is a volume of semen. We need to make sure that only the volume of the semen sample will change. It will become reduced if there is a less abstinence. Otherwise, the parameter doesn't have a change. So we need to give him good counseling, so which will be helpful for him to collect the semen sample. In case if there is any retrovated, infected semen sample, the density gradient is the best method to get rid of it. If you feel the viral load is more, prepare the semen sample before the insemination. Before the patient is undergoing for IUI. Take the post-choice, send it for the post-viral count. You can see what is the difference between the prepared sample and the raw sample, the viral count. Then you can subject into him for the IUI preparation. So this one thing which I wanted to highlight on the IUI is the patient will undergo a situational sexual dysfunction on because of the stress. Because if you will just mark a calendar and say that you need to produce a sample on this day, the day would have been bad for him. This is happening in the thing. So what happened is, if you see a man which is having any problem in collecting semen sample, if you anticipate, ask him to go ahead with the cryopreservation before that. So this cryopreservation, once if it is having any, so it will be helpful for him to collect the semen sample on the day, because he'll be having a backup of this. In case if it is not happening, is these are the different medicines which will be subjected into it. One is sildenafil, tadalafil, vardenafil. But these things, along with a proper counseling and proper giving him a proper thing, then he will be able to collect the semen sample. These are the vibrators and different vibrators which are, this vibrators also can happen. The only thing is vibrators cannot produce the erection. It will produce the ejaculation. So it is can be helpful for men to collect the semen sample. And don't forget that cryopreservation will help him a lot and give him a boost, because he'll be having a semen sample at the backup on his mind. So he'll be able to get the fresh sample as thing. So my take-home message is very simple. Just guys, I mean, the suitable semen sample should be method should be there for each and every sample depending upon the other parameters. And also, if the collection to the insemination time is important, it should be less than 90 minutes. And there's any addressing of the difficulties in this cycle could be overcome by the next cycle, and cryopreservation can be used as a backup. So thank you so much for your patient listening.
Thank you, Dr. Ramesh. It was an excellent and elaborative talk. You also highlighted on collection difficulties and method of collections. No, that is very important for any practice. And also you highlighted on all the semen preparation techniques, which we also should know on and off. We should be like, going through that and understand, because all the time you'll only focus on IVF and clinical side. And also we should know about the technical aspect of IUI. And really, there is one thing is about the normal sperm, because we don't see a normal semen parameters in our centers. Like overcomes, there is always a like teratospermia somewhere or there. All the count, everything normal. One line is teratospermia, because we know it is a 4%, more than 4% is normal. I would like to ask you again, like, if how, like, if it is less than 3 or 2%, can we consider as normal and repeat, or can we ask them to go for natural in a younger patient? Because most of the time, every parameter is normal, wife is normal. This only one thing says that only 3%. Okay. So this situation, what do you do?
3% usually I consider it as a normal, ma'am, because 3 to 4% is normal. Less than 3, 2 or 1 is definitely abnormal. Maybe you can subject into for antioxidants, and you can repeat the semen sample after 3 months.
Okay, so thank you, Tapisar and Oxy, for giving me this opportunity. And is there any question answer session now, or ma'am, how do we take it?
Ma'am, we're actually going ahead with the next session, which will be the panel, ma'am.
Okay, thank you, Dr. Ramesh. Thank you.
Thank you, ma'am.
Thank you, Ramesh. Thank you for a nice presentation. And you have put forth all the practical things what everybody should know in the clinical practice. And really, we greatly appreciate your presentation. Thank you so much.
Thank you, ma'am.
Thank you, speakers and the chairpersons. We are going ahead with the next session and the last session of the day, the panel discussion on IUI success. May I request Kundavi ma'am, HOD Senior Consultant at IRM MMM, who is my teacher as well. Ma'am, welcome you to introduce the panelists, ma'am.
Yeah, thanks, Madhu. I think it's my pleasure to be here with my friend Jaya and the team Tapisa, Roxy, and the Foxy. My pleasure to invite Dr. Archana Ambujam, Dr. Nitya, Dr. Rajapriya Ayappan. I think she'll be joining us. Dr. Karpakambal, Dr. Surya, Dr. Priya Kannappan, Dr. Vanitha Sri, and Dr. Priya Kannan for the panel. Let me try my... Yeah, can you stop? Can I go ahead and share the screen?
Yes, ma'am.
Let me try my luck. Can you see?
Not yet, ma'am.
Can you see my slides?
No, ma'am.
No, the way it is not it. I think you have to share. Initially, it was seen a little, but now not. Try sharing. It's not sharing.
It is starting.
Can you?
No.
It was
It's not shared.
Yeah, Chitrakala, can you share?
Yes, ma'am.
Can you see now?
Not yet, ma'am.
Ma'am, shall I, ma'am?
Steady the idea. Okay. Start. Yeah.
Yes,
Yes, you can go ahead.
Yeah. Now we can see.
No, I can't see actually. Yeah. Okay. Can you see my slides now?
Yes, ma'am. Yes, ma'am.
Chitrakala, next slide. This is a panel discussion on how do we improve the success rate of an IUI. Next. Yeah, is selection of patient necessary for increasing the success to improve the pregnancy in IUI, and is it really necessary? And who are the candidates for IUI? Dr. Priya, Rajpriya.
I mean, the ideal candidate would be somebody who will have survival factors or sexual dysfunction, and we have to make sure that we have enough follicles in the female factor. We will have to plan. Ma'am, are you able to hear me?
Dr. Karpur?
Yes.
Yeah, there's a little.
Yeah. No, are you able to hear me now? Now it's better.
Yeah. Now it's better.
So,
next slide. Yes.
So
next slide. Dr. Karpagam, what are the indications for an IUI?
Yes, madam. The main indication is it's ideally been designed for asthenospermia. Most of the time, it's male factors of fertility, and also in cases where we have had minimal to mild endometriosis, IUI leads to good success. It can be used. And in unexplained infertility, where you're not able to find out the cause, so the next step that we can definitely opt to is an IUI. And most of the time, in patients where there is an ovulation issue, and it also, we have tried enough cycles of simple ovulation induction, then we obviously go for the next step is IUI. And in the cervical factors, and most importantly, the sexual dysfunction, where the sexual performance is definitely a big problem in spite of counseling and in spite of medicines, and IUI gives a hope for them to parent a child.
Yeah. Dr. Who are the patients where you will not do an IUI, the contraindications for an IUI?
Definitely. Sorry, okay.
Main contraindications to IUI, the first and most important is the female age, basically the poor ovarian reserve. Secondly, the tubal factor, at least one tube should be patent, otherwise it is a contraindication. And severe endometriosis, of course. And also when it is a severe male factor. Only for mild male factor problems, we can go ahead with an IUI, otherwise we have to think of other ART treatments.
So what do you mean by mild male factor, Dr. Archana?
Mild is most commonly astenosospermia, and the most important is the total sperm count. If the total motile sperm count is more than 5 million, we can consider going ahead with an IUI. When it's less than between 5 to 10 million, we can consider going ahead with an IUI. When it's less than 5 million, it is not advisable to go ahead with an IUI.
Next slide. Next slide, Chitra. Yeah, we were just listening to Dr. Anuradha, right? She said, do we really need to evaluate the tubes before the IUI? If so, if people agree, who are the patients where you do an HSG? Who are the patients? Would you go with the lab, Dr. Nitya?
Ma'am, it depends on various other factors as well. On the age of the patient and the duration of their infertility and their previous history also. If there are any signs or history of any PID or patient had any previous history of surgeries or ectopic pregnancies, then probably, and if the duration of infertility is more than say 4 to 5 years, then we would probably counsel the patient to go for a diagnostic laparoscopy. But then again, it's important to tell the patients about the options first.
Dr. Archana was saying if it is one tube that she may not be doing it. So what about you? One tube is patent, another tube is blocked. Would you still go ahead with an IUI or tell them to go ahead with an IVF?
Yes, ma'am. We can't go ahead with IUI even with a one patent tube. If bilateral blocked, then probably no. But if there's one patent tube, after counseling the patient, I would still go ahead with an IUI.
For example, if she produces a follicle on the right side and the tube is on a patent on the left, Dr. Surya, would you go ahead with an IUI or would you tell them to go ahead with the timed intercourse? Dr. Surya?
I would like to go ahead with the IUI, ma'am. There is something called transperitoneal migration of the site. So there are chances for pregnancy even if the ovulation happens on the tubal block side.
Okay, if one tube has gotten hydrosalpinx, the other tube is patent. Dr. Priya Kanappan, would you still go ahead with an IUI?
Yes, I mean, depends upon the hydrosalpinx. Yes, ma'am. Can you hear me? Ma'am?
Yes, we can hear you. We can hear you.
Yes.
Yes,
in
yes,
the
Priya.
hydrosalpinx, all know that the fluid can be like embryotoxic. The chances of her getting a success with an hydrosalpinx there, it's very less. So we will counsel the patient. If the patient insists, it's no wrong in trying that. But anyway, we know that the success is going to be less with one hydrosalpinx sitting there. So at least either we'll do a tubal separation and then you can try for IUI. I mean, if the other tube is normal, or otherwise, I think natural intercourse would be a better option for her. I hope
Next
my
slide. Next slide. Chitra. So on what factors does the success of IUI depends? Next slide. The factors affecting the success of IUI depends upon the age, the duration, the cause, endemic receptivity, and various therapies. What you have from Dr. Ramesh. And the of
Ma'am, you're not audible, ma'am. Kundavi, ma'am?
Ma'am, we can't hear you. Kundavi, ma'am?
Dr. Kundavi, we are not able to hear you.
Trying to reach through to Madam, sir.
Can you hear me?
Yes, now, ma'am.
Yes, ma'am. Now we can hear you, ma'am.
Yeah. Move the slide. Move the slide. Chitrakala, can you move? Can you hear me, please?
Yes,
Yes,
ma'am.
ma'am. Yes, ma'am.
Audible, video also clear, ma'am.
No, yeah. What is the age cutoff where would you say that you would not do the IUI? Dr. Vanita Sri?
Ma'am, more than 35 years, generally it falls. If we do it less than 30, it's good.
30 to 35 is okay. More than 35 generally, and again, we go with the AMH of the patient. The success rate is a bit low after 35 years of age. Also, we consider all the other factors too, ma'am.
Okay. Dr. Priyakannan, when would you say no to IUI? At what age you would say, yes, I will not do the IUI? We would definitely go ahead with an IVF. Is Priya Kannan there?
Ma'am, I think she had issue. She left, and I think it says that she left.
Yeah,
So
anybody can take the question. At what age you would say that you will not do the IUI?
Definitely 40 years ago, we will not do, madam.
I don't think we can say that I will not do, because if affordability becomes an issue, she has never had treatment before. She just got married recently. Today, late marriages do happen, right? But we have to put it across to her that maybe she can try a single cycle or two, because the results are going to be compromised. With that understanding, if the patient is willing to try, only then we can offer. But we cannot dogmatically say on this age, I won't offer in Indian standards of economics, where the patient spends for their treatment.
How do you counsel when a patient comes at age of 40 and the success rate, Priya? You said that you know to
cut your video, Kundavai. Your network is so weak. Cut your video so that your audio will be well heard, ma.
Yeah.
And we will definitely tell the patient. Now, first of all, when we look at today's, if their fertility is very good. So even if the female factor is very good, she is a very, untouched patient. She's just married 1 year. We have to tell her that at this point, her antral follicle reserve, even though it is there, the quality of the follicles will go down because of the age per se. So it is sensible to understand that IVF will give her a better chance, like say 6% versus 20% or so. And if the woman says, I absolutely can't, I'll offer IUI. Otherwise, definitely when we tell the patient that time is sleeping, is a better option. So that's how they will be counseled.
Next slide. Yeah. What is the duration of infertility and the success? And again, when would you say no to IUI?
Yes, ma'am. Duration of infertility affects the success rate of IUI. When it is more than 5 years of infertility, I would give the option to the couple choose between IUI and IVF. I may not tell them no, but I'll give them the option of IUI and IVF. Long period of infertility, yes, it has impact on the success rate of IUI.
Okay. Dr. Nitya, if a patient says we have been married for, next slide, please. If a patient says that she's been married for 5 years, but they're only living together for 1 year, what would you do, Nitya?
Then definitely we, after evaluating and just making sure there's no other combined factors, I'll probably go ahead with the IUI, ma'am. But also we'll
how many cycles of IUI would you? Yes, Nitya.
Ma'am, maximum
how
of
many cycles would you try?
3 or a maximum of 4 after evaluating her tubes.
Okay. Next slide, Chitra. I'm stuck with my slides. Next slide. Yeah. Dr. Priya Kannappan, does the etiology affect the pregnancies? What is your personal experience? Which of the conditions would give a better success rate?
Yes, madam. Definitely PCOS, the moment the patient
It's a tubal factor or an endometriosis or a PCOS. Yes.
Actually, like tubal factors, the chances with IUI are very, very limited, madam. The chances of pregnancy with IUI are very less. And definitely when there is an endometrial pathology there, definitely our IUI is going to fail. But if it is just an ovarian factor or a male factor, the success is definitely better. So if it is like, for oligoacinospermia, we know that IUI definitely improves the sperm quality. And for PCOS, when the ovulation happens and if it is unexplained or any other reason, where we take it as some immunological reason to be there, then IUI gives a better success rather than having a tubal or an endometrial factor.
Also,
next slide. Dr. Karpagam, yeah. Who's that? I just start.
Yes.
Dr. Karpagam, like for an endometriosis, like how many cycles of IUI would you prefer to do?
Madam, it depends on the
Is
age and
Karpagam
the
there?
severity of the endometriosis. Yes, I'm here, madam. Can you hear me?
Okay, go ahead. Yeah.
So it depends on the age of the patient and the ovarian reserve and also the type of endometriosis. Actually, I would do endometriosis only in minimal or mild endometriosis and not in moderate or severe endometriosis. So in that case, definitely mild endometriosis, we have had quite a good success rates. And those are the people where I would definitely consider doing IUI. And the question is asked is, does it matter whether the cycle is natural or stimulated? So very rarely I do natural cycle IUI, madam, because whenever we are going for natural cycle, we expect to get maximum one follicle. But with stimulated cycles, even with letrozole, we get at least sometimes in a good, absolutely no female factor, we get 1 or 2 follicles, the chance of pregnancy increases. So in IUI, majority of times, I do only stimulated cycle. Initially with absolutely no female factor, I would do only with letrozole, ovulation induction and IUI. If still not clicking, then I would go with gonadotropins, which actually gives a good success rate, madam.
Dr. Surya, is there any group of patients where you do a natural cycle IUI? Dr. Surya?
I may think, yes, ma'am. I may think for two group of patients. One is when I ran for a donor sperm IUI program. The next one is sexual dysfunction. If they have not had a successful natural intercourse at all, in those two group of couple, I may try for natural cycle. But I would even like to go for triggering, ma'am. At least the HCG trigger I would like to have.
Okay. Dr. Archana, Dr. Karpagam was saying that she would go with the stimulated cycle. So what is the rationale behind of the stimulation protocol? Dr. Archana?
Yes, ma'am. Yes, ma'am. So when you stimulate we generally tend to, one, in anovulated patients, we can be sure that she's going to form a follicle and ovulate. And we want to get at least 2 or 3 follicles so that when we have more than one follicle, we have better success, better fertilization with the sperms.
Next slide. This is what we have found that, the gonadotropin cycles had a better pregnancies, about nearly 15% compared to with the letrozole or CC. Next one. So again, the CC plus HMG had a pregnancy rates about 13%, whereas a pure FSH plus an IUI produced better pregnancies of about 28%, but the risk of twins are very high with the stimulated ones with the gonadotropins. Next. So number of follicles, will influence the IUI outcome. So how many do we aim? Dr. Rajapriya.
Definitely, most of us would want at least 2 follicles, but sometimes we end up with 3, and we need to have a cancellation policy in place. Now, supposing she's a hyper-responder and you're tending to get more than 3 or 4 follicles which are going to be dominant, then we need to discuss with the patient that she might end up with multiple pregnancy. And I think when we are doing this at the outset of the program, when we get what we want or when we get more than it, then it is better to rather than to give one of the instructions and push her into a situation of OHSS. So if she has agreed, then maybe comfortably I may go on the dose. Otherwise, more than 3 follicles, I would cancel the IUI and make it into a either sexual abstinence if they are very clear they don't want twins or multiple pregnancy, or else if they are okay with twins, then I would allow them to go for their natural intercourse. So a cancellation policy has to be placed whenever there is a hyper-response.
Priya, like sometimes we see in this PCOS, they do have empty follicles, right? So would you have a check of doing an estradiol level when you see too many follicles?
And when we have too many follicles, then we also tend to look at the endometrium. How is the endometrium? So normally there is a dialogue happening between the follicle quality and the endometrium. So supposing it looks the endometrium is very thin, I have a doubt on my quality of follicles, I would do estradiol. Whenever I see a lot of free fluid coming and follicles which are looking really vascular, then again I might do an estradiol. Otherwise, it is not routine practice for me to do estradiol.
Dr. Vanitha, do you aspirate the follicles and then go ahead with an IUI, or would you cancel the cycle as Dr. Rajapriya?
If it is more than that, again, we have to counsel the patient prior, ma'am. If they're willing to go for aspiration, we can go ahead. Or if they're not prepared, then we have to cancel the cycle. It's again.
You won't convert it to IVF?
In my setup, I'm finding it difficult, madam. I'm not able to. So I counsel them prior itself. And then if they're willing and they're able to manage the finance, then I convert. I mean, rarely I've converted. Most of the times I've cancelled the cycles.
Yeah. Next slide. I think the maximum, the 3 follicles, I think the pregnancy rate is about 16%, but more than 4, I think your success rate also comes down with the increased risk of hyperstimulation. The patient safety is more important. Next slide. This is something like premature LH surge. So how many of you all have faced this premature LH surge? And if so, what have you done for these patients? Dr. Priya Kannappan.
I mean, like premature LH surge usually happens if you have more follicles, madam. I'm not seen with 1 or 2 follicles per se. So, I mean, if at all, like, sometimes what happens is that we never see a follicle at all. And then we feel that, okay, we'll call her after a day or 2. And that time she comes and she ovulates and she comes. So that is how I have encountered with that. And if that is 1 cycle is there, then the next cycle I call her frequently. I call her every day. I make sure I monitor the follicle clearly so that, I don't miss the window for that. And one or 2 patients I've tried with antagonists as well. So that to avoid the premature rupture in IUI cycles. Yes. So few cycles I've tried, I've given them antag so that along with the gonadotropin, so that the gonadotropin will stimulate and that antag will prevent the LH. And then I've gone ahead and given SCG and I've also got pregnancies as well. Yes, I've done that.
I think with the previous history of follicle rupturing at 14 millimeters or something, I think that cycles, the next cycle probably you can give them an antagon cycle as well. Next slide. I think we'll move fast because another 10-15 minutes I'll finish the panel. Next. So I think Priya said that she would prefer to give an antagon. Next. And this is what the studies have also proved that antagon can reduce the incidence of a premature surge and especially with useful for the non-PCOS patients. Next. And why is the timing of IUI is very important? How many of them will prefer 24 hours as somebody will prefer 36 to 40 hours?
Ma'am, we prefer doing it at 36 to 40 hours, ma'am, not at 24 hours unless we are planning for a double IUI. So most of the cases we go with a single IUI only. In those cases, 36 to 40 hours is what we're looking at.
Any rationale behind that 36 to 40 hours magic number?
Ma'am, it is just that, the ovulation, studies have shown that, anywhere between 24 to 40 hours after a HCG trigger IUI can be done. But however, we will want to see the follicular rupture on an ultrasound. And also the patient is convinced that there is a rupture, and then we can also be sure and then go ahead with the IUI.
Next slide. Do all of you all agree for 36 to 40 hours?
Yes, ma'am.
Yes, ma'am.
36 to 40, I agree, madam, but I don't wait for the follicle to rupture and then give IUI. I somehow prefer to do the IUI before the follicle ruptures.
So when would you do, Priya?
36 hours, but most of the time at 36 hours, the follicle doesn't rupture, madam. Usually it ruptures after that. I've never seen, whenever I see that, I've never seen a follicle rupturing at 36 exactly.
So would you bring them back again? It could be still a lutein is unruptured, right? So would you bring them back again?
Usually I call them the next day, madam. After 12 hours, I repeat that. And still if the follicle is there, maybe we do a double IUI as well. So it's the option for the patient. We give the option to the patient.
So how do you counsel for a double IUI, Dr. Archana? Because sometimes the husbands may not be able to produce a sample the next day. So how do you counsel? Dr. Priya says she would do a double IUI. So what would you do, Archana?
Generally, single IUI is good enough, but if we encounter a problem like what she has, generally I look for the rupture, and between 36 to 40 hours, I find most of my patients have ruptured, so I really don't have this problem. But patients with low counts, sometimes we do a double IUI, that is at 24 hours and again at 48 hours.
So I think Archana's patients are very lucky they rupture, whereas Priya, you just find out the trick, what she's doing for the rupture of the follicles.
Yes, ma'am, I'll do
Can we
that.
have the next slide, please? Maybe the trigger, what you give? You give Ovitril or recombinant HCG or a urinary HCG? Is there any
Urinary
difference?
HCG, ma'am.
Okay.
Urinary only, ma'am.
Urinary only. Okay. Nitya, I just wanted you to tell me this because you have lot of liking towards the Doppler. So how do you decide the time for the trigger? Any special trick? You have done a lot of studies on that. Dr. Nitya.
So on the day of trigger, we would like to see the Doppler, the perifollicular Doppler. So when the PSV is more than 10 and when the RI is less than 0.5 is an ideal time for us to give the trigger. So when the PSV is indirectly, it is also a measure of the LH surge. So when the vascularity is good, that it should at least be more than 50% around the follicle. And as the PSV increases, it tells us about the LH surge also. So the studies have shown, and we've also done a study, that when the PSV was more than 15 or between 15 to 20, these patients had an earlier rupture of follicles. So instead of traditionally calling the patients 36 hours later for an IUI, these patients, when the PSV is higher, we can call them on the very next day itself to check for the follicular rupture. And then if it has ruptured, then we can go ahead with the IUI. So the chances of them rupturing earlier with PSV of more than 15 to 20, the follicles rupture even at 24 hours.
I think people swear that, the success rate of IUI from 15 to 20% goes to 80%, but I think still we'll have to look into it. And what is the rationale of triggering 20 millimeter with CC cycle with 18 with gonadotropins? Is there any rationale?
Yes, ma'am.
For that
Usually
size?
the CC, sorry. CC,
Yes, Priya.
usually there will be a negative impact on the endometrium. So you give an extra few, a day or so that the follicle grows a little bit bigger. You have more estradiol, the endometrium develops a little bit better with CC cycles. And because the CC has a negative impact on the endometrium, whereas it's just a gonadotropin, if you're going to use, there is no negative impact. So even at 18, your endometrium is already ready. So there is no difference between that, and that is the reason we trigger a little later with CC.
Next slide. How important do we really monitor the endometrium? If the endometrium is thin, do we cancel or do we add all masalas there? Anybody could take that, Dr. Vanita?
We don't cancel. Check the endometrium, the follicle. And if it is less than 7 to 8 mm and there is no triple line, and in the Doppler, if the vascularity is not good, then we can add estradiol and other things to help in improving the endometrium lining, actually.
Do we add other adjuvants like aspirin and all those stuff for an IUI?
Yes, ma'am. If generally I don't add, if needed in the next cycle, then we will start and do it. Usually I don't. With most of the times with just estradiol, it is fine.
How long do you continue the estradiol valtrate? When would you stop it?
Usually just before the trigger, ma'am. Like when it is around 9 mm, 8 mm with good triple line, then I just stop. And then
is a difference between estradiol valtrate and hemihydrate. People talk about both.
I'm not sure about it, ma'am.
Okay, next slide.
Hemihydrate seems to have a better bioavailability rather than the valerate.
How true is it, Madhu? Because people talk about hemihydrate.
Yes, ma'am. Hemihydrate is a new component which they say the bioavailability is more, and so instead of giving twice daily dosage of the other components of estrogen, hemihydrate is able to reduce the amount of dosage, and it is able to also increase the bioavailability, increase the thickness, increase the vascularity per se.
Okay. I think this is a study where they found that if you have endometrium more than 9, the pregnancy rates are better and the miscarriage rates have come down. Next slide. Chitrakala, yeah. We talk about the luteal phase. Do we really need to support the luteal phase in IUI? If so, what drugs would you give? Yes, Madhu.
Not routinely, ma'am. Not in a routine case of IUI do we have to, but if there has been an induction with gonadotropins, then yes, a support system would be needed because more than one follicle, if there is a formation of more than one follicle, yes, there is an extra support that may be needed. In case the endometrium has not been congruent and we have given or started on the estrogen component, then even continuation of that estrogen beyond the trigger, beyond the IUI until the date of urine pregnancy test is the common norm. Routinely, IUI doesn't need a support.
Dr. Surya, what sort of a luteal support would you give? Would you give them an oral or a micronized or an injectable one?
I give a oral natural micronized progesterone, ma'am. Usually for ovulation or stimulated cycle, I don't prefer to give a luteal support. Only if the agonist trigger is given, or else if there is some problem with the endometrium, then I would prefer to give luteal support, ma'am.
So which patients do you give an agonist trigger?
If I used an antagonist in case of premature LH surge, in those patients I give, and when the follicles are more than 3, I feel the free fluid is more, in those cycles I give agonist trigger.
With an agonist trigger, Rajapriya, what are your luteal support? Do you really give like an IVF or what supports do you give them if you have 3 follicles and it's triggered by the agonist? Rajapriya.
Ma'am, I wouldn't give an agonist trigger on an IUI cycle. Ma'am. I do not have experience with agonist trigger on an IUI cycle.
Because they say you can reduce the multiple pregnancy rates by giving an agonist trigger. Yes, Madhu.
Needs a very intense luteal phase support in that case, ma'am. Obviously, an estrogen combined with a progesterone until the date of the urine pregnancy test or a beta HCG is recommended.
Okay, next slide. I think we've got another 3, 4. Again, is only with the use of gonadotropins. I think we still give progesterones, though we talk about it is only, evidence-based only with the gonadotropins. I think whether it is with the tablets or with the gonadotropins, most of the people tend to use the progesterones. I think we are live with the progesterones, right? We sleep with the progesterones, we get up with the progesterones. Next slide. Next. Is there any difference in the quality of the sperm? So we are all clinicians. I think we don't have the embryologists over here. Probably if Ramesh Raja is here, he could also join.
I'm here, ma'am.
Priya is there, ma'am.
Yes,
Priya is there.
Priya is there.
Priya, okay, Priya, I just really missed you. Is there a difference between the quality and the quantity? How do you decide whether that patient has to go for swim up or a density gradient, Priya?
Ma'am, actually, when we go by the statistics and the publication that's given, ma'am, there is absolutely no difference in the pregnancy rates when we use either swim up or a density gradient. That is what the publications have always been maintaining. But if you see a little bit of more of teratozoospermia, then it probably would be advisable to go for a density gradient. When we are looking at semen preparation for IUI, ma'am, it has been consistently shown that we don't have to complicate the semen preparation to have a better success rate. The key is to have the simpler, the lesser the time we take from the collection to the insemination. That is where the success rate is much better, and that's all we need, ma'am. We can use either HEPs or fertilization media. We can do whichever we want, but then the simpler the technique, the better the sample that we actually start with. That is what gives us a better success rate, and none of the procedures have shown to have a better success rate over another, ma'am.
Priya, from the time of ejaculation to the time of insemination, what is the time duration would you really advise the clinicians to go ahead?
Ma'am, the maximum I always advise about 1.5 hours, ma'am, just as a max, because if we say, ma'am, the sample is collected, 20 minutes is liquefaction, let's say, even if it takes about half an hour, that's the time it liquefies. And then the preparation time is about 45 minutes. So in 45 minutes, so that means in 1 hour and 15 minutes, it's definitely is ready. So that is when we should start inseminating. and by max for the patient to get ready and come and lie down and do all that stuff, maybe another 15 minutes, ma'am. But then from the time to collection to the insemination, it can be between 1 hour to 1 hour and 15 minutes, at the max 1.5 hours, ma'am.
Priya, now a lot of people talk about microfluidics. What is your take on that, microfluidics for an IUI? If so, which patients?
Microfluidics something quite innovative, ma'am, but I have been using it to a certain extent when the first IVF has failed, IUI has failed, or after 2 IUI failure, I've been trying to use it to see if it improves the results. I don't have that much data on my hand personally to say it improves or it doesn't improve, but publications have not given anything. I think we need more publications about microfluidics and IUI to actually come to a conclusion. But personally, I've started using it, but it's I don't have that much data to say how much it has improved my success rates, ma'am.
Priya, like, people talk about less than 1 million to about 5 million to about 10 million for the IUI, right? So what is your message to the audience over here?
Ma'am, the one we have, we have so many publications, ma'am. The few things that definitely improves IUI success rate is, one, to select the sample that actually we start with. There is something called an IUI-able sample, as I call it. It's not a scientific word, and samples which are not IUI-able. So in essence, when you have a male infertility, it is not actually, when it goes something like, you don't start with, every lab can have its own cutoff of the pre-wash and the post-wash semen sample to go for an IUI. At least about 5 to 10 million motile sperms in any sample would be a good pre-wash sample to start preparing for an IUI. If the total motile sperm count is not even 5 million in that sample, then obviously the result is not going to be great using that sample. In a post-wash sample, the total motile sperm count should be at least 1 million. If it is about 2 to 5 million, the results are much better. But the least that you should have is about 1 million total motile sperm count.
Okay, next slide. I think the optimum, as Priya has given very clearly, about 1 to 5 million. Next slide. Next. I think each one of you all can take this question. The type of catheter, does it make any difference, Dr. Surya?
No, ma'am. Type of catheter don't make any difference. I use the sturdy catheter in case of difficulty in negotiating the internal nerves. Otherwise, I go for the simple catheters, ma'am.
Rajapriya, if you have a difficult IUI or somebody comes to you for you to have in the second cycle, what would you do, Priya?
First of all, once we have to check if the patient is anxious over the results. So calm her down, use pre-warmed instruments, have a variety of instruments, and then make sure that you're talking to her as the procedure goes and whether she's comfortable at every point. There's also important for us not to clutch on to her cervix when she's not psychologically ready to handle any pain. Giving a bit of mild analgesic or anxiolytic the previous night also might help her to allay her fears and anxiety. Most of the time, trying to splint the speculum and using the whole procedure very gently works.
Would you do with an ultrasound guidance or something if there's a difficult IUI?
Yeah. Now, if I have, if I feel like it's a very tight cervix and I will not be able to negotiate it, I will definitely do a trial catheterization and I will use ultrasound guidance even before the actual procedure day, because I already know it's a difficult catheterization. So the cervix is looking very, sometimes, the cervix doesn't smile at you. You may not exactly know how to cannulate yours. In that case, yes, I would do a trial catheterization with a bladder full.
Sometimes if you have an IVF center, you can still use a stillet as well. Next slide.
Yes.
Next. This we have already spoken. Yeah, I think Dr. Priya said the influence of the success rate. Next. And people have some shorter the time duration within the 30 minutes. So probably, I think we all know that the latest laws that it has to be processed in the same center, not to be transported to the other place. Next slide. Next. So again, how many of you will do a single versus double? Dr. Priya Kannappan said she would do a double insemination. What about Dr. Surya?
Where the follicles
I go for single, ma'am.
We go
Okay.
single well-timed IUI, madam. I never do double IUI.
You don't do double IUI. Okay.
No, no, no. I
But
never
if the,
do
if the
double IUI.
patient says that the other center, like, pre-follicle rupture and post-rupture, would you do?
No, madam. However it is, then we can do. Whatever it is, I don't do, madam.
Okay. Do all agree that we won't do a double IUI?
No, no, no. Single well-timed
We'll go
IUI.
for single.
Because
Okay,
the success
next.
rate is not very different from that, madam. So it is.
What about male factor, Karpagam? If you have a mild male factor, would you still do because some evidence says mild male factor, you can do a double IUI.
No, madam. Even then, I would ask them to. Actually, I might do a pooled IUI, madam, rather than a double IUI.
Okay. How many of you have done a second ejaculate, as Dr. Ramesh said?
It's very
Yes, ma'am.
stressful, madam, actually.
Yes.
It's
Yes,
very
it is,
stressful
but-
to do another sample all of a sudden. So I always believe that, single well-timed IUI is good enough.
Okay, next
But
slide.
sometimes, yes, ma'am, when the male partner is the sample first when it's produced and it is not of good quality, definitely a second ejaculate has its own role. Not for every man who comes to the clinic that we are not going to say, no, go and discard this one and go and give a second one. But there are some patients who are really indicated, and for them, definitely second ejaculate has a role.
Yeah, I agree with you. Next slide. Ultrasound guided versus the clinical. So how many of you will do an ultrasound guided with the half-filled bladder and?
If it is the first time, if I have difficulty, I use this ultrasound guide, madam, but not for that. And in some centers, it is readily available and they do it as a protocol. So when that facility is given to me, I really prefer to do it ultrasound guided. Otherwise, clinical touch is fine.
There's not much difference
yeah.
as far as the clinical trials are concerned, whether it is a clinical touch or an ultrasound guided. But practically speaking, clinical touch in normal cases is enough. But in cases of difficult IUIs or previously indicated ultrasound guided IUIs being done, will help in easing and getting the good pregnancy rates as well, ma'am.
Sometimes you can make the patients comfortable showing that where the sperms are going. They are very sure that the husband's sperms have gone inside. Next slide.
It's very useful in acutely antibody and acutely retroviral uterus, madam. It's very, very useful. Ultrasound is very useful in such situations, madam.
Yeah, because we are running a teaching institution, so we make sure they do it in the proper way, and the sperms, the IUI is also very straightforward and the smooth. Next slide.
I have one point to make. Am I allowed?
Yes, Dr. Anuradha.
Yeah. So what I do in my center when the vial comes, before loading into the catheter, I show that name, that label to the patient.
Exactly.
That this is your husband's, and I load in front of them so that they will not have any other thoughts. That's what I do.
Yeah, I was about to ask these people because we normally show them the name, the ID number, the date of birth, because you can have two Shankars with the same name. So it has been documented that it has been shown, and the patients also do understand that their husband's sample has gone inside. So final to it, like does insemination volume and the rest. Priya, and then what is the insemination volume would you advise? Would you give it to us?
Ma'am, at a maximum of 0.3 to 0.5 ml, ma'am.
Okay. And what about the rest following the IUI?
At least 15
We
to
generally ask 10 to 15 minutes, ma'am.
Okay, next slide. So I think we have just come with 0.5 because normally it is only 0.3 to 1 ml because 0.5 alone goes inside the things. What precautions, what syringes to be used, and Priya? Any special syringes you load?
Ma'am, the syringes usually the only thing is it is better that if we don't use the syringe with the plunger, but one thing we can definitely be sure in an IUI catheter, ma'am, unlike a IVF embryo transfer run where the culture media touches the plunger in an IUI catheter, when we are aspirating the volume, the prepared sample into the catheter, there is very minimal chance that the sample actually will touch the plunger. So there need not be a special syringe in terms of an IUI, ma'am.
Okay.
It's okay
Thank
if you
you.
can use any 1 ml syringe.
Okay. Next slide. I think we are finishing with that. So coming to the take-home message. And what about the consent? Anybody could tell us regarding the consent for the IUI? And especially consent with the donors forms. Yes. Yeah.
Ma'am, there are few places that we need to have the signatures of the patient when we are doing the IUI. Number one is the form for the identification of the semen sample that the couple signs saying that this semen sample is theirs. That's the first thing, along with Aadhaar or whatever we want to give that. And the government has, the law has already also given one consent form for the IUI and another form for donor IUI separately. So both needs to be filled and signed by the patient and also by the clinician as well. And along with this, for any IUI, it is an ART procedure. So we need to have the identification of the patient and the marriage certificate also to be done. So it's an ART procedure. We need to have the backup paper saying that they are married couple and this is the couple that we are going to give the sample to, ma'am.
How long one consent is enough for the patient for the entire? So, for example, you're doing 3 or 4 IUIs. One consent is enough for every IUI you take a consent.
It's best to take the consent every time we do the IUI.
And how long do you keep the consent?
Even if you are doing a double IUI, it's best to do one today and one tomorrow. It's best to have separate consent forms, ma'am.
Okay. What about how long do you maintain the consent forms for the IUIs?
Ma'am, how long?
5 years, 10 years?
Yes, ma'am. I think it's given 10 years or so, ma'am. We have to, just like any IVF or embryo transfer or pickup.
Definitely, yeah. So I think the take-home message, next slide. The various factors depends upon the age of the patient, the duration of fertility less than 4 years, the semen quality, the semen preparation techniques depend upon the initial semen, the count and things, the timing we have discussed, and the number of inseminations probably we have decided, and the mild stimulated cycles is better, and the 15 minutes bed rest. Next. So I think we'll have to follow the national guidelines, and probably the best laboratory practice and cost-effective things should be done. And again, the financial issues to be discussed, whether we are going to use the FSH or an HMG, because probably the low-cost IUI should be better. Medical legally, we'll have to be very careful because the consent forms is very, very crucial for us. In case they divorce or something, probably unless the court tells you to give the consent forms or the complete patients maintaining all the issues to be given, unless otherwise the court tells you to give those documents. Safety issues to be seen because we need to screen them for an HIV and HBsAg as well, and make sure that the screening parameters always looks normal. Next slide. I think the success depends upon the various factors and depends upon a good talk between the clinician and the laboratory persons. Next. Thank you so much for the panelists for the wonderful discussions what we had. Thank you. And thanks Dr. Jaya, the Oxy, Tabitha, for giving me this opportunity.
Thank you, Madam.
Thank you so much, Madam. And thank you, one and all, to all the panelists who have been there with Ma'am. And such a fastest kind of a class that we would have had. We would have revised everything, a very quick brushing up of complete IUI. Thank you so much, Ma'am. Thank you so much, one and all. Can I now request Dr. Sharad Bhatina, sir, to give his vote of thanks as a conclusion of the webinar, please. Sir?
Thanks.
Thank you, Kundavai, and thank you, panelists, for the nice, very elaborate and very crispy and a very good teacher-student presentation we had. Thank you, Kundavai, and thank you all the panelists for joining with full enthusiasm. Thank you so much. Over to you, sir.
Thank you for the opportunity, ma'am.
Thank you, Jaya. Yeah. Good evening, everyone. I thank Jaya Rani, the convener, for giving me this opportunity, pleasant duty of this proposing vote of thanks. No? So we were honored to have Dr. Amit Patki, the president of ISA, to be the chief guest, and Dr. Jaideep Tank, and the president of FOXY, and Dr. Madhuri Patel, the secretary general of FOXY, to be the part of our program. We are thankful to Dr. Sujata Kar, vice president ISA, and Dr. Sanjeev Reddy, the past president of TAPISAR, for accepting to be the guests of honor. I'm thankful to Dr. Kalpana, the chairperson for Infertility Committee FOXY, and Dr. Jairani, the dynamic Dr. Jairani, the past president of FOXY and the vice president of TAPISAR, for making this program an academic feast. I'm thankful to all the speakers and the chairpersons for making this academic feast a delicious one. I'm equally thankful to the technical team for making this program successful. Thank you, one and all. Thank you.
Thank you, sir. Thank you.
Jaya, would you like to take up one question with patient have said that I think which is very, very crucial question. Patient from remote area, no access for follicle monitoring. Can we proceed with ovulation with electrodes or a CC blindly for 2 to 3 cycles? I think I would say no.
Yeah, if she is not a PCOS, if she's a normal one, you are just super ovulating her, you can give her. But if she's not if she's a PCOS, definitely not. But if she's a normal one, you want to just super ovulate, you can try if she's very young. But all the things not more than 2 cycles, because if you don't see her a basal scan, you can't just like that give ovulation induction, because sometimes we may end up with a hemorrhagic cyst, which may end up in a chocolate cyst also. So this can happen with any super ovulation, which is not being monitored from the day 2 of ovulation induction. So always it should be monitored, which should be the take-home message for all the people here. But just since you asked, I'm just telling, but never we do for PCOS patients, because we can't be assured of how she will respond.
But sometimes I've seen people giving blindly the clomiphene or letrozole.
Very many people.
And I've seen one of the gynecologist's daughter-in-law lost her ovary because of that. The ovary became too big and the surgeon thought it's some tumor or something, and he removed the ovary as well. So I think people have to be very careful.
Remote areas.
Thank you. Shall we conclude this session?
Yes, sir. Yes, sir.
Thank you so much. No, thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you, madam.
Thank you, Anuradha. Thank you. Thank you, Anuradha. Thank you.
Thank you, ma'am.
Thank you.